with our noon conference. So we're doing another Zoom noon conference live here at the U with some residents who are sitting in the room with us who are going to be participating. So the last couple times we've done this, we've had the audio go out about 15 minutes in. So at any point, if you can't hear us talking in this room, please go ahead and put in the chat, let's say, Danny, I can't hear you, and we will briefly stop and call back in. That has been fixed both prior times. So with that, Mike Pham, one of our excellent residents, and Kathryn Huber, who's on the call today, are going to help us out with a case that they are going to present. So, Mike, take it away.
Hi everyone, I'm Mike. So I guess our first, the case for her is down in the surge ICU. But this lovely lady, female, history of bilateral lung transplant, 2016, first COPD, and a couple other risk factors, hypertension, obesity as well. Presented from the University of Colorado, ED for shortness of breath for 3 days. Notably, she was admitted about 5 days prior for COVID-19 pneumonia with fevers, chills, and initial onset of symptoms about 8 days ago or so. She was discharged at that time with 1 to 2 liters of oxygen from baseline of really none during the day, maybe some intermittent nocturnal oxygen. She was discharged to complete about another 5 days of dexamethasone.
About her recent hospital course, focus question about her recent hospital course.
So, I don't know if you mentioned this, but when she was admitted last after COVID, was she intubated? What was her highest oxygen requirement?
She's gotten up to maybe like 4 liters. She was pretty stable at most, but she's not intubated, was just unstable on the floor. And just left hospital with a little bit of oxygen requirement.
All right. Great question, Spot. For really clarifying what her last hospital course looked like, how much oxygen she was on, et cetera. And then, Mike, any additional details about the days between discharge and readmission?
Absolutely. She had initially felt a little bit better, but just in the last couple of days prior to presentation, she started feeling short of breath again, having some fevers. I think those are the main complaints. And not kind of continued productive cough as well, yellowish sputum, and then still needing her oxygen for short of breath.
For the interns in the room, any additional focused questions for Mike about the review system between discharge and readmission? All right. So we got no additional questions in the room, which is great. Mike's going to give us some more history. So, Mike, tell us more about this person's past medical history.
Yeah, she had a history of pretty severe COPD emphysema. Eventually got her transplant in 2016. At that point, has been feeling pretty good since then. I guess, okay course for her. Just general headache complications with like post-surgical operations, but feeling a lot better. Back to previous kind of baseline activity for her. She has a new lease on life.
Great. And then for our interns in the room, you know, when I was an intern, I was not super familiar with lung transplant, obviously. And none of us in this room are pulmonologists, but I think we have a couple on the call today. But Mike, tell us a little bit more about her post-transplant course.
I guess mostly notable for post-transplant.
No, it's all right. Mike, while Mike's looking some stuff up here, so this lady underwent a double lung transplant in 2016 here at the university. Following double lung transplant, she's been on immunosuppression, which we will get to in just a second. And so the questions we typically ask people when we're evaluating their post-transplant course is, have there been infections? Have they had to go back to the operating room? Have they had any episodes of rejection or any other sort of complicating factors? Okay. And so what Kathryn is actually going to do right now is Kathryn's going to zoom in and tell us about her post-transplant course.
Following her transplant in 2016, she's been using about 2 liters of oxygen nightly for the baseline. She takes tacro, everolimus, prednisone 5, as well as azathioprine. She's been followed pretty closely by the transplant team as a follow-up. I believe when she underwent her transplant, she was positive for EBV. And since then, she has had a history of CKD stage 3 to 4. So all of her medications have been renally dosed. She is on prophylaxis with Bactrim and Valsite, and has not been treated with antifungals prophylactically. I think that's all that I have.
Awesome. Kathryn, that's excellent. So that's a great review. So basically what Kathryn went through was when was the transplant, how much oxygen she's been on since then, her immune suppressing regimen, which we'll talk about in just a second, making sure she's followed, and then any complications. So CKD, whether that was from the medication she was taking or something that she just developed naturally, and then if she's on prophylactic antibiotics, then are those the appropriate prophylactic antibiotics. So here's her medication list. And for one of our upper-level residents in the room, go ahead and point out to me what you guys think the most critical or sort of most important medications are on this list.
So the big thing is a lot of immunosuppression. So you got tacro, you got everolimus. Other things to think about as well is prednisone's on there as well. So just kind of tells you like the baseline amount of like immunosuppression. Another thing to look at is what kind of prophylaxis they're on. So they're on valganciclovir, azithromycin. And those are the big things I look at. Oh, azathioprine, I forgot that word. So.
Yeah, absolutely. And so one of the questions I had when I was looking at this medication list, and Schweik's completely right, is this azithromycin, is this prophylaxis or is this for something else? And when you actually look at the Pham transplant notes, it turns out that this is actually for concerns about sort of chronic graft issues or sort of chronic graft inflammatory issues. So her azithromycin is actually not dosed for infection, it's dosed for more anti-inflammatory properties. So sort of similar to our frequent exacerbators with COPD. But you're exactly correct. So her valganciclovir, that's treating or prophylacting for CND, and then her Bactrim is prophylacting for PJT, or pneumocystis jirovecii pneumonia. Excellent. So regardless of what happens to this person, every single time you guys are ever admitting a person who has an organ which is not their own, you should talk to the service that chronically manages that transplant. It's both a nice thing for continuity of patient care, and it really helps sort of bridge the gap between the outpatient and inpatient side of the hospital. All right. So, Mike, go ahead and tell us about her initial vitals and her physical exam in the emergency room.
Yeah. Initial vitals, she was pretty uncomfortable, but I guess.
That's all right.
All right, initially she was afebrile, but trending there, 38 degrees Celsius, slightly past 108, pressure is 150s over 60s, respiratory rate was 39, SpO2 was 93%, initially just on 60. In exam, no acute distress. She is ill appearing and kind of slightly respiratory distress, but otherwise comfortable, able to kind of speak sentences for initially. Otherwise, exam is remarkable for just tachycardia. Pulmonary exam, normal effort, no breath sounds, no wheezing, no stridor noted as well. No focal findings on respiratory.
Oh. So basically, she's a very ill-appearing woman. She's more hypoxic than her baseline. And she's sitting in the emergency room and she's about to be admitted. So, what are additional data you guys want here?
You said she was like 30-something. What does she actually look like in terms of ancestral muscle use? Like, we worried about shooting her ED versus having her weight. And it's the only part. Cheers, smoke.
infection as well. Potentially some other there are other known kind of viruses that can induce acute rejection as well. There are other major things coming in. She had rapidly increasing O2 requirements over the night that prompted intubation several hours later.
Great. So this lady will ultimately end up intubated. All right. So getting right to her labs here, because we're going to have labs when she comes in. So we sort of know she ends up intubated, but what did her labs look like prior to that? So she has a white count of 13.2. On her BMT, she's got a little bit of an AKI on CKD, 31/1.85, but labs are otherwise normal. Her lactate is 4.3. Her procal is 2.88. Her ABG score, as you can minimize the chat up there, her ABG is 7.47, 25, 53 on quite a bit of heated high flow nasal cannula. And if one of our interns in the room could analyze that ABG for us, that would be fantastic. Jake, take it away.
Love it. All right, so based on the pH, it's a alkalosis that we have. Her CO2 is the correct me around the 25, correct? So consistent with a respiratory alkalosis, and also has that bicarb of 31, which is probably then a concomitant metabolic alkalosis as well. And tough to say which is which, honestly, but just like, yeah, I don't know which came first, but I'd presume maybe the metabolic alkalosis, just because it would take a second to compensate otherwise. So.
Yeah, perfect. So I think the one thing I'm about to confuse John, so this is where I write my BUN, and this is where I write my bicarb. And so he actually, yeah, no worries. So I think he actually has probably a normal bicarb or a slight non-gap, but otherwise you're correct. It's a respiratory alkalosis. And then most importantly, Jake, what do you make of this number right here, which is her PO2?
So if she's on heated high flow, I mean, her PF ratio is absolute garbage on this, so kind of consistent with the needs for intubation.
Perfect. Yeah, so this lady is profoundly hypoxic on already a fair amount of respiratory support. You get some micro back. Her Legionella and her strep pneumonia are negative. Her COVID RNA is positive. It was positive last time she was in the hospital 5 days ago. And her blood culture showed no growth. So this is her admission chest x-ray, which we're now projecting up there. And so if one of our upper levels could give us their kind of focused read of this chest x-ray. Cassandra, I nominate you. Sorry, Cassandra was mid-cookie when I nominated her.
She has multifocal alveolar opacities bilaterally. One was the first day. Otherwise, let's say she maybe has fluid or something accumulating on her right pitcher. And then otherwise, trachea looks like a little bit sort of deviated towards her right, but I don't know if that's promising or not. For her, with her transplant, too. That's a big bit of processing. And then there's your work devices. Yeah.
Perfect. So Cassandra just gave a great focus read, and so what we're looking at here is bilateral multifocal opacities. So sort of the white stuff here, the white stuff here, here. Really everywhere you look, she has these kind of white ground glass opacities, consistent with a multifocal pneumonia. And I'll tell you that this is worse than the last time she was in the hospital. And if Dr. Connors is still on the call, if I saw him logged in, if he has any additional thoughts to share on this chest x-ray, that would be fantastic.
Yeah, thanks, Danny. Nice. I couldn't hear everything, but I think you're right. It is a multifocal pneumonia. It's an acute bilateral infiltrate, causing acute hypoxic respiratory failure. So you can just go ahead and call this ARDS if you want to. It depends whether you say this is from her previous infiltrates and this is just a continuation, in which case it's more than 7 days. But we're sort of just splitting hairs at that point. The movement of the trachea is related to the rotation. So you'll see right shoulder back. So that is just her trachea going around her aorta because of her age, augmented by the fact that she's rotated And you'll notice that there's a lot of distortion of her fissures. You know, that minor fissure where that infiltrate is pulled down on the right. Well, I guess we could argue it's down, so it's being pushed by something above or pulled by something below. And then there's that lingular infiltrate that's pretty impressive on the left side.
Perfect. Thank you, Dr. Connors. So, we'll take a brief interlude.
Sorry, she has a wide mediastinum, but it's just important to note that once you have a transplant or your chest cracked open, you will have a wide mediastinum for life in most cases. So that's not pathologic. That's just who she is forever.
Excellent. That's a great teaching point. I actually was not aware about that. So I thought we'd take a brief interlude here and sort of do some phases of COVID. So these are just a random collection of chest x-rays I took from patients that I saw in the surge ICU in April and that were in the surge ICU last month. And so if you'll notice, a lot of these x-rays could most generously be described as absolutely abysmal. The left one at the very top has some of the best air bronchograms that I think I've ever seen. You essentially can see the entire silhouette of the bronchial tree on both sides. The one in the middle has diffuse alveolar opacities both sides, and the one on the right has diffuse alveolar opacities and sort of progressing towards the white out of that right hemithorax. And so this is what the bad x-rays look like. So what do the good x-rays look like? So right now, these are 3 x-rays just from a random collection of people that are sitting on the HMS4 service, our floor COVID service. And as you can tell, they're A, significantly better, and they're B, they're sort of all the same type of pattern. And that pattern is sort of basilar, predominant, and peripheral. And so you're seeing those same sort of ground glass opacities, but in the basilar, predominant, peripheral pattern, which has been sort of the most common way we've seen the radiographic abnormalities in COVID described. And so, you know, there are reports of consolidations in COVID and sort of anything, if you're on, you know, MedArchives, you can find any report of anything right now on COVID. But I think the top ones are pretty classic for the people that get extremely sick, and the bottom ones are pretty classic for people that we see do okay on the floor. All right. So we have officially now diagnosed this lady with ARDS. And so what I want to do right now is go to our whiteboard and let's create a differential for what we think is going on with her. Mike brought up a couple things early on, but let's get through a differential here. So for our people in the room, just as a quick reminder and recap, she was admitted 5 days ago for COVID pneumonia. She was on the floor, had a little oxygen requirement, discharged, and is now coming back feeling worse. And she's about 15 to 16 days into her total illness. So let's go ahead and give a top 3 of what we think is going on.
Superimposed
Multilobar pneumonia.
Okay.
Or that.
So we've got a multilobar pneumonia. And should I have any additional qualifiers to that pneumonia?
In terms of,
Like, would you say it's like thought of bacterial?
oh, I see. Yeah, I would say it's slightly bacterial potentially, given the recent hospitalization. But could be whatever.
The recent hospitalization, we're sort of maybe calling into question, does she have a HAB or a hospital-associated pneumonia or healthcare-associated pneumonia? Great.
You have to have viral on the list too. She just tested positive for COVID.
Okay. So is this all just COVID still happening? That's fantastic.
And with her degree of immunosuppression, also opportunistic infections like fungal or other.
Great. So Sam, one of our third years, is this an opportunistic infection or an OI? And then we'll add a 4th one on there, because I think people are still have some pretty good ideas. Anything else?
So the thing I kind of worry about is with people who have lung transplants, sometimes you get the lymphatic vasculature a little bit disrupted. So I'm wondering if she just has a lot of just pulmonary edema, essentially.
Okay. So pulmonedema. Great.
Danny, could this be acute rejection as well?
That's what I was looking for. So Levi says, is this acute rejection? Perfect. I think that's a great list. So you guys are hitting whether it's bacterial, is this viral, is this COVID, is this an opportunistic infection based on everything else that's going on with her, pulmonary edema, and rejection. So one of the really nice things you guys just did, right, is our kind of general blood, pus, and water schema when we're thinking about alveolar filling opacities. So go through this every single time and see if you can create a differential. And, you know, in this case, right, rejection is actually kind of going to be one of the 4th ones that we invoke, which is cells. So does she have an increase of cells there, which is causing rejection? So really nice job, everyone, both outside of the U and inside this room with you, with creating a differential. So we have diagnosed this lady with ARDS, and we are going to now treat her for ARDS, and we'll pretend in this situation that the attending and the fellow are nowhere to be found in the surge ICU, which is absolutely not a situation that happens. But one of the really interesting things about the way we sort of treat ARDS is that the order in which the landmark studies came out is sort of the same order in which we do stuff. And so what do you guys want to do? We know this lady gets intubated, but what's the first thing you guys want to do once this lady gets intubated? Great. So Cassandra says she wants to do low tidal volume ventilation. And so for either our interns or upper-level residents in the room, what is low tidal volume ventilation?
6 to 8 cc's per kilogram ideal body weight.
Perfect. So 6 cc's per kilogram of ideal body weight, which is IBW. And then as a bonus question, does anyone know what study came out in 2000 which told us that this was the thing to do? ARDSNet. Perfect. It was the ARDSNet group. And then what was the specific name of the study? Anyone know? That's right. So the ARMA study from the ARDSNet group came out in 2000. So the very first landmark study that we had telling us how we decrease mortality in ARDS was the ARMA study in 2000. And the first thing we do for patients is put them on low tidal volume ventilation. So as an additional aside, ARMA compared 60 cc's per kilogram with a plateau pressure less than 30 to 12 cc's and a plateau pressure of about 50, which we clearly don't do anymore. And the 60 cc's per kilogram was associated with a decreased mortality, a huge decrease in mortality. That's the first thing we do for our patients. So after we intubate them, what's the next thing that you guys want to make sure we're doing? Yeah, after we do lung protective ventilation. So we set our ventilator, they're on lung protective setting, 6 cc. What's the next thing we want to keep in mind? Yeah, great. So Anthony picked up on what's happening here. So in 2006, the FACT trial came out. As Dr. Bull, one of our pulmonologists here, will tell you, he floated the first swan in the FACT trial. That's his claim to fame. And so for our upper-level residents in the room, what did the FACT trial tell us? Perfect. So Anthony's a little farther from the mic, but what Anthony says is dry lungs or happy lungs, and Bill is saying run dry, less ventate. Perfect. And so what FACT said was if you keep someone dry, so once they're out of shock, if you diurese them, and you sort of keep them at a net neutral volume status, you decrease their ICU stay, you decrease their time on the ventilator, and you make their oxygenation level higher. There was no change in mortality, but I think all of us in the room can agree that those are objectively good things. All right, so you tell your fellow, I've intubated them, I put them on low tidal volume, I'm keeping them dry, and then Mike will then come and tell you that this person's next AEG on 100% oxygen is 7.47, 28, and 80 on an FiO2 of 100%. So what is the next thing that we want to do for this person?
What's their PEEP?
Well, first thing I'm also...
Perfect. Say that one more time.
What's the PEEP?
Oh, what's the PEEP? The PEEP is 14. Great question.
Right.
Yeah, the PEEP is 14.
Well, the other thing I also make sure is that we're actually on low tidal volume ventilation, because that's a pretty low PCO2. Yeah.
Yeah, so that was, the PCO2 might have been incorrect. I might have been under that one. But we are on low tidal volume.
Okay, cool.
So this is not a user error. And so what Sam said in the chat is we want to prone this person. And so another question for the people in the room, what is the name of the study that told us that proning was beneficial? And it came out in 2013. The chronological order was still holding. Perfect. So ProSiva came out in 2013. And what ProSiva said is that proning is great. And again, another kind of upper level question, how long do we want to prone these people for? So your fellow will walk back in the room and say, hey,
how's the word? Maybe like 16 hours.
So Cassandra says we want to prone for 16 hours. And then just an additional teaching point, in the study, to meet criteria for being prone, these people had to be on an FiO2 of at least 0.6, I think it was greater than or equal to 0.6, or 60%. They had to be on a PEEP of at least 5, so greater than or equal to 5. And our patient clearly meets that criteria. And then they had to have a P to F of less than 150. And when I was a medical student, I actually didn't know how to calculate a P to F. And so for our interns and sub-Is and AIs in the room, the P to F ratio is going to be your PO2, so in this case it's going to be 80, over your FiO2 as a fraction. And so 100%, like Dr. Connor says, makes the math easy. It's 80 over 1. But let's say if it was 80%, then it'd be over 0.8. So our patient's P to F ends up being 80, which is catastrophically low.
Dan, can I ask a cool question?
Yeah.
Do we make any adjustments here in Denver based on the barometric pressure that we have?
That's a really good question. I will defer that question to Dr. Connors. Dr. Connors, Schweib asked, do we make any adjustments in Denver based on the barometric pressure of being at altitude?
It's a great question. Like everything else in the ICU, is some people do and some people don't. If you want to make the correction, then you can use 127 as your cutoff. I don't, because several of the centers in France where they did Perceiva were at altitude. And so you have some centers doing altitude, some not, and they all used 150. But you'll find some purists here who use 127.
Perfect, thank you.
Great. All right, so we have low tidal volume, back, we're keeping them dry, Perceiva, we're pronating, and this person is still getting worse. The patient is dysynchronous. So what do we want to do next? And my timeline is, I'm fudging a little bit. This is 2019 now. This kind of old, 2019. So what do you guys want to do now that this person is dysynchronous, while prone, and still getting worse? Awesome. So Bill's saying sedate more, Levi's saying sedate and paralyze. The group here is invoking the Rose trial, which is great. So the Rose trial came out in 2019, and actually we were one of the centers that participated in it. And what the Rose trial did was it basically went back and re-examined a study called Acute, which came out in sort of, I think, around 2014 or so. So that's where my timeline doesn't really check out. But what they looked at was, does neuromuscular blockade early make a difference? Does paralyzing someone make a difference in terms of mortality, ventilators, all those sort of things we look at in all of our other studies? And what they found was that, sort of dissimilar to Acute, was there really was no difference. Early neuromuscular blockade did not decrease mortality. It actually led to some worse patient outcomes in terms of like cardiovascular outcomes, post-ICU, muscle issues. And so the big takeaway from Rose, at least here, is that you really only paralyze someone if they are dysynchronous or sort of still getting worse. It's more of a salvage therapy. And Dr. Kyle, I'd be interested to hear your thoughts on the Rose trial.
Yeah, you told it exactly right. You know, it's hard. Most of the people who designed and did Rose didn't believe in paralysis, so equanimity was not necessarily there. I think people were sort of looking for the result they got, although they did a fine trial. You know, the argument is that the Acute worked because we used to use a lot more sedation than we do now. Truthfully, we still use a fair bit of sedation. So I would try to sedate somebody. I would not paralyze them if I didn't have to, but I don't hesitate to do that when their P to F is 80 and they're failing and I need to take them out of the equation.
Great. And so this patient was indeed paralyzed. And so as Mike and his team expertly did, the patient kept getting worse. They got paralyzed for quite some time. All right, so this right here is how we manage ARDS. So this is from 2000 to 2019, and then COVID came in, and we all lost our minds, started doing a lot of stuff. But through all of that, a few things have actually made a difference. So, Mike, what treatments did you give this person for her COVID, or what did she receive for COVID last time she was in the hospital?
She initially got a course of remdesivir.
Awesome. So she got remdesivir, a medicine that none of us had heard of until about 6 months ago, and now we'll never forget. And then she also got dexamethasone. So, for some of our residents in the room who have done the surge service, so Garrison here, some of our upper levels have done the surge service, who is getting remdesivir? Which patient?
Everybody except for patients.
Great. So everyone who's in the hospital without CKD is getting remdesivir right now. And, you know, we can talk about the studies if you will in just a second here, but just baseline, right? If someone's getting remdesivir, what should our ideal outcome be? Like, what did that study hopefully do?
It didn't show mortality benefits, but ideally it was.
Cool. So, great, yeah. So no mortality difference, but it increased recovery. And so it basically increased the number of people that recovered, and then Levi's saying it decreased the length of stay. So again, objectively good thing. And sort of the weird qualifier with remdesivir is that it didn't really seem to make a difference in people that were intubated or on ECMO. Their sample size was just too small to say anything definitive about that. But people who were on oxygen on the floor, it did make a difference. Okay, so we've said the word recovery. So now we actually need to talk about dexamethasone and the recovery trial. So who is getting dexamethasone in our hospital?
People within their 2 requirements.
Yeah.
Great. So Chris is saying if you're on oxygen, you are getting dexamethasone. And how much dexamethasone are you giving these people, Mike? So Mike's giving them 6 mg daily times 10 days, or until they get extubated or get taken out of the hospital. And then for people in the room who have had time in the last couple months to read, which probably shouldn't be everyone, what did that recovery trial actually show?
So the mortality benefit in intubated patients, and I can't remember, I don't think it showed a mortality benefit in patients just on looking at oxygen. I can't remember who had or not.
Great. So Garrett actually got it exactly right. So Garrett, I saw Garrett and Dr. Burnham reviewing this study together last month while sitting in the surge ICU, which is excellent. And what it said was that it had a mortality benefit in people that were on oxygen. So if you weren't on oxygen, it actually had a trend towards increased mortality. But if you were on oxygen, it decreased mortality. And that number basically went from 25 to 21%, which is why we are giving these people dexamethasone and remdesivir when they're in the hospital. Any questions about the adjunctive COVID therapies? All right. So Mike, you guys also did some other stuff for this person. You consulted palm transplant. And what did palm transplant tell you about the rest of this person's medicine?
Yeah, they initially, initially were worried about rejection as well, in addition to all the other things we had discussed. So they wanted to continue, at least initially, her backbone of immunosuppression medications.
Okay.
That's a change, but yeah.
And then what else did the bone transplant service tell you? Any notable teaching points about the immune suppression, how we treat rejection, et cetera?
I mean, the biggest things, like the concern for anyone coming in for concern for infection, we were about immunosuppression for one, of opportunistic infection, which potentially may be possible for her, but she's on the kind of appropriate prophylactic coverage for her as well. But also, anytime people coming in with acute as well, when we worry about rejection, we kind of want to balance between concern for infection and potential shock with rejection as well. Particularly in those with transplants with organs that aren't more easily replaced, like pretty much anything but the kidney, where you have dialysis as backup.
Great. So that brings up a great point. So anytime these people come into the hospital and rejection is on the differential, you really have to balance infection versus rejection. So do we have enough data to say what's infecting them, or are we more concerned about rejection? And it sounds like in this case, Mike, correct me if I'm wrong, the home transplant service was much more concerned about this being an episode of acute rejection.
Initially was more infection, but then as she got more acutely sick the day after was when they got really concerned about rejection.
Perfect. And that's why they went back, right, and cycled through and said, continue her immune suppression, and we'll give her some other medicine. And what other adjunctive therapies did you guys give her to actually treat possible rejection?
She initially got treated with IVIG, or stress dose steroids first, methylpenicidine, and then IVIG.
Perfect. So Kathryn also brings it up. Kathryn was the intern on the service. Did an excellent job. So IVIG and additional methylpred. So as Mike had said early on, this lady had actually still been taking dexamethasone when she left the hospital, and she got additional methylpred and IVIG when she came back due to concern for acute rejection from COVID. Dr. Connors, do you have any additional thoughts about transplant stuff?
No, I think that sounds totally reasonable. You know, this is one of those situations where you were going to give steroids anyway, and so you kind of get off easy because they may be doing double duty here, both for the ARDS associated with COVID and the rejection. And I think, you know, outside of a biopsy, you just don't know, and so it's all a clinical diagnosis.
All right. So let's go back to talked about. This was the first study that looked at remdesivir in our COVID population, and so sort of fittingly, this was called Act 1. I don't believe there's actually been an Act 2 yet, and they haven't actually given us all the data from the study. But this was Act 1, and this is their Kaplan-Meier curve. What I really just want to point out is right here in patients that were receiving oxygen, that remdesivir blue curve was higher than the red curve, which is placebo. And if you look then, right, it's here and here, patients that were on invasive mechanical ventilation and patients that were on ECMO, you see that that's a more purple line, which is not ideal in this particular Kaplan-Meier curve. So we're only really seeing it diverge in people that were on oxygen, which means there were people in the hospital. And then this study, right, this is the recovery trial that we just talked about. This was a study done in the UK. It's a really fascinating study. I highly recommend everyone read it. And here's the Kaplan-Meier curve from recovery. And in this one, you want your dexamethasone line to be lower than your black line. So the other line is care, the red line is dexamethasone, and mortality is on the y-axis. And the notable finding from this study is the top right corner, or sorry, the bottom right corner right here, the no oxygen received group. And in the no oxygen received group, the dexamethasone is actually higher than the usual care, showing that there's increased mortality. And so I'm going to pose this question to you guys in the room. Why do you think dexamethasone may have increased mortality in people with COVID who were not on oxygen?
Infection.
Okay, Cassandra says increased risk for infection. Perfect. What else?
You also need your inflammatory response to actually fight off the COVID. So if you're dampening your inflammatory response, make it worse.
Great. So Schwab's saying, is there something about the time course where if we give steroids too early, we're affecting the person's ability to respond to the COVID infection? Cassandra's saying concern for infection. And what Schwab is actually bringing up and Cassandra brought up is exactly correct. So I have borrowed this slide from Dr. Johnson, one of our ID attendings here. It's an excellent slide. And this slide basically combines the inflammatory issues with COVID with the viral transmission issues with COVID. And so down here at the bottom, viral load, transmission potentials in the middle, and then inflammation up here at the top. And so what this tells us is that early in the course, so it's in the first 2 weeks, you're at higher risk for issues from viral replication. This is when the COVID is really running rampant in your body, but we're not seeing a lot of those sort of physical effects. We're not seeing people on oxygen, we're not seeing them coughing, we're not seeing terrible illness. But then when you get into sort of weeks 2 through week 4, that inflammatory burden gets higher, and that's when people really sort of light themselves on fire in the hospital and really, really get worse. And so early in the course, what Schwab is saying, it's helpful to have an antiviral because we want to stop this process. But later in the course, this is when we really want, this is when we really want our anti-inflammatory. And our anti-inflammatory, right, is dexamethasone. And right, if we give that anti-inflammatory too early, for instance, if we give it right here, then we're probably just going to make this curve go back up. But if we give it too late, then we sort of miss the boat on the high inflammatory portion of the illness in the middle. The fascinating thing is they actually went and looked, Gilead, the pharmaceutical company, went and looked to see if 10 days of remdesivir was different than 5 days of remdesivir, and they actually did find a statistically significant difference. And one of the reasons people think that might be is if people are presenting to the hospital at this part right here, maybe they really only need 5 days of remdesivir. Whereas if they were coming in early, maybe they need that full 10 days of remdesivir. So just things to be aware of. What questions do you guys have about COVID, about sort of ARDS, about this person's course so far? So Jennifer's asking, are we allowed to give remdesivir ourselves? I believe that we still need IV to give it. Garrett,
you can just call them whenever. So like if it's overnight, like they prefer you to call them, they'll look at they'll give you clearance. Basically, it's like their LC normal and their kidney function normal. Like everyone just gets it.
So what Garrett was saying is that we can give remdesivir to everyone as long as their kidney function is normal. You basically just need to ID consult the next day.
I think the LCs have to be like 3 times or something. You have to limit it.
Gotcha. And the LCs have to be less than 3 times the upper limit of normal. Maybe. Sure.
Something like that.
That's Garrett's personal practice. That's a great question, Jennifer. Yeah, and just Dr. Connors was saying that you do need ID to give it restricted, so the ID does need to be on board at some point during this person's course, and they should be anyway because the person is in the ICU with COVID. All right. Mike, tell us how this lady's doing, sort of what happened in the interim.
Yeah, initially got broad spectrum antibiotics. Then there was some concern for rejection, where she would kind of receive these medications. So she continued to kind of develop worsening heart, required intubation, intermittent, kind of everything that we discussed with aggressive, or not aggressive, conservative fluid management and intermittent proning as well. Kind of complicated, course was complicated by acute renal failure that required CRT. And kind of with that, at that point, kind of titration of different medications, particularly immunosuppression.
And how is she doing right now?
She finished the initial course for, or initial concern for hospital-acquired pneumonia. Fortunately, had another kind of worsening. She improved ventilation-wise, had another hit, concern for VAP as well at that point, and started another broad spectrum antibiotics. She had gotten to the point where we actually tried to extubate her. I guess I don't know how far you want to go.
Yeah, you're going.
Tried to extubate her earlier this week. She only tolerated for about an hour or so, now reintubated, unfortunately.
And is there anyone you guys are talking to now that she's failed extubation?
Yeah, so, I mean, continued talks with Pham, transplant, and the ID team. But now that she's failed intubation, we kind of gave her a shot as the surgery team for trach.
Great. So talking to CT surgery or any surgery team about the possibility of getting a trach on the person. And I'd be interested to hear Dr. Connors' thoughts, but I think I think the general public is very concerned about trach. Trach is one of those things, like when we're in med school, you hear and you assume that everything gets bad if someone gets a trach, and that's really affecting their quality of life, their ability to function. But realistically, trachs are what help people start to mobilize in the ICU, help to work with physical therapy, and sort of help them on the road to recovery. And so consulting someone for a trach is something that we should all sort of become more comfortable with when we talk to families, because it's something, especially with COVID, that we're going to be doing more and more. So I'd be interested to hear Dr. Connors' thoughts on sort of the trach discussion, timing, et cetera.
Yeah, I completely agree. We were one of the first places, not the first place, but there were many places where when you reached day 21 with COVID, that was the end of the course for you. We trached people along with a couple other big centers and said, look, let's just see if these people get better at day 42 and 50. And they did. And if you recover, your trach comes out. The only people whose trachs are permanent are those who just don't recover from their disease. And they obviously will have a bad course anyway. So I think of it as a way to get people to a sunnier day. And if they have hope for recovery, then I don't hesitate to trach people, even with COVID. And there are places you'll see in the community that they talk about early trach. They'll trach people on day 3 or 4 and just sort of try to help them get out of the hospital. That's never been shown to be beneficial, but somewhere in that day 14 to day 21 window is probably most appropriate.
Awesome. And I think that's obviously a multidisciplinary discussion between Pham transplant, surgery team, and then of course the patient's family or their decision makers. So I wanted to end this conference. We've got about 12 minutes left. The surge month is just a generally hard month for people. I only did surge for about 12, 14 days when I was a third-year resident, and it is emotionally draining. Every aspect of it is emotionally draining. And so I sort of wanted to end this conference by hearing reflections from Garrett, Mike, and then Kathryn on the call about sort of what the surge experience has been like, what your kind of biggest takeaway is from the surge experience, sort of what either how your practice will change going forward or how the surge experience will change your residency thus far. So we'll start with Mike here because he just grabbed the mic.
I'm not good with awkward silences. Okay. I guess my big thing is like it's definitely tough from my experience with people in this month as well. Just like for obvious reasons, that they can't have family come in and visitors by the bedside, and that just makes it challenging, kind of keeping them updated and kind of continued conversations about just how sick their patients are, and if it gets to the point where you're having more goal to care conversations, it's tough for patients' families to see their patients usually walk into the hospital, breathing, talking, pretty normal, maybe just a little bit short of breath, and then kind of they're not really fully understanding kind of the different things that we talked about, like intubation, proning, paralysis, all the different things that we're doing for them, and just not truly understanding how sick they are just for the fact that they're not there with the patient, seeing us around and seeing everyone thinking about their loved ones. And just kind of having that transition to to the next steps if you need to. But that's kind of been one of the challenges I face, but just more, I mean, we've been calling every family, the primary kind of family member every day in the unit as a just practice for every patient to try to work on that as well. FaceTime is needed, but that's kind of been the big there are a lot of other things that have come up, but that's kind of one of the main challenges.
Okay, I appreciate that, Mike. Kathryn, what are your sort of experience, thoughts on surge service?
I found it's been a really good experience because I hadn't had very much exposure to ARDS prior to this month, and then it was, a lot of ARDS every day, so I felt like I got pretty comfortable with it by the end. One of the things that was challenging for me that I didn't expect to have to deal with this early in my training was in dealing, kind of like what Mike said, with families, because so much of what we do it's still changing and it's somewhat experimental at times. Like, for example, talking to patients about convalescent plasma. We had a couple of family members who were really concerned, and, they watch the news and see how, one day it's approved, one day it's on hold. And then they are asking us as the primary team, what do we recommend to take care of their loved one? And because we're not necessarily the one consenting them for those interventions, trying to walk that fine line between counseling them as a caregiver, but also counseling them as we don't really know what this will do for your loved one. And I think that is a challenge that we don't normally come up against unless we're working in some of these areas that use more experimental therapies. Because normally what we do, we know we have evidence for, and we can kind of talk families through it. But when it is a little bit more gray area, kind of challenging. And then this is also an area that families watch the news all the time, and they have lots of questions about different political aspects and experimental aspects of the things that we do. And that was a new challenge that I wasn't expecting, in addition to all the normal COVID challenges.
Yeah, absolutely. I couldn't agree more with that. It's really difficult to not have the families there and deal with both the social stuff, the political stuff, and then the actual clinical aspect of it. And then, Garrett, any additional thoughts?
Oh goodness, you guys said a lot of things that I was thinking. Yeah, I think, kind of back to like what Mike was saying, I think one of the challenges is, unlike other patients in the hospital where visitors are now kind of back in the hospital, I think it's going to be hard without kind of I have a microphone, cool. Like not being able to like physically interact with family members and kind of provide that kind of emotional connection that comes with physically being present. I think it just makes it more emotionally difficult to communicate what's going on in the hospital with family members. Yeah, I don't know. Kathryn and Mike kind of said a lot of what I was going to say. So.
Well, thank you. The third team this month did an awesome job with a schedule that, no joke, changed quite frequently. So a huge thank you to Mike, Garrett, Kathryn, and then our upper level residents, Levi, Emily, Victor. Everyone did a phenomenal job covering nights and days. Patients got excellent care. And right now, because of their work, we're down to 6 people there. So technically the third service is on hiatus.